Welcome to another episode of Deep Dive Medicine.
Great to be here.
Today we're tackling a topic that comes up all the time in clinical practice, and honestly, it can be pretty perplexing. Evaluating thyroid function tests, or TFTs. We're looking at the pearls, the pitfalls, based on a really key article that's often debated, actually.
Right.
It helps navigate these tricky scenarios.
Indeed. TFTs are, super common labs, but interpreting them, not always straightforward.
Right.
You get results sometimes that just don't match the patient in front of you, right? Discordant results.
Yeah.
Or they even contradict each other, like high thyroid hormones, but the TSH isn't suppressed. Or the flip side, high TSH, but normal hormones.
Exactly.
So our goal here is really to give you a more structured way to think about these, anomalous results.
Okay, let's dive in then. When you get those confusing TFTs back, where do you even start? What's the first thing?
The absolute first most critical step. Always revisit the clinical context. Just looking at the numbers against generic reference ranges, that can be really misleading.
How so?
Because so many things affect those ranges.
Yeah.
Ethnicity, iodine intake, gender, age, BMI, and especially pregnancy. They all shift what's normal.
Got it.
And remember, TSH is usually the first test, the screening test, but it's definitely not foolproof. Think about things like non-thyroidal illness or assay interference, central hypothyroidism. Even rare things like TSH secreting pituitary adenomas or resistance to thyroid hormone. You can miss those if you only look at the TSH.
So the big pearl is context first, numbers second.
Precisely. The numbers are just one piece of that clinical puzzle.
Okay, so beyond the baseline patient factors, what are some common things that, mess with the results, make them look weird?
Right, the confounders. Well, a really big one we see often is non-thyroidal illness, or NTI.
Yeah.
And the key here is that it's not a thyroid problem itself. It's the body adapting to some other acute or chronic illness.
So the thyroid's actually okay.
Fundamentally, yes, but the TFTs look off. You might see low or maybe low normal, free T4 and free T3, and the TSH could be normal or sometimes even low.
Interesting. And then during recovery, the TSH might temporarily shoot up. Recognizing that pattern is crucial to avoid misdiagnosing hypothyroidism when it's just the body recovering. Right, that makes sense. What about pregnancy? That's a whole different ballgame physiologically, isn't it?
Oh, absolutely. Huge changes. Estrogen goes up, so thyroid-binding globulin goes up, which pulls up the total T4 and T3 levels.
Okay.
And then you've got HCG, human chorionic gonadotrophin. Early in pregnancy, first trimester especially, HCG can actually stimulate the TSH receptor a bit.
So that acts like TSH.
Kind of, yeah. So
Yeah.
it can raise free T4 slightly and suppress the actual TSH. This is often called gestational transient thyrotoxicosis.
And that's usually temporary.
Usually, yes. But it's really vital to tell that apart from something like new onset Graves' disease in pregnancy. Measuring SHRAB, the TSH receptor antibodies, is super helpful there.
Good point. Now, what about patients already on levothyroxine? We see lots of folks whose numbers just aren't quite right despite treatment.
Oh yeah, anomalous TFTs are very common there. And often it's down to pretty practical things.
Like,
Well, first, maladministration. Are they taking it correctly? Not with food or coffee or certain meds like iron, calcium supplements, PPIs. Those interfere with absorption.
right, timing matters.
Big time. Then there's malabsorption itself, maybe undiagnosed celiac disease or echlorhydria, not enough stomach acid.
Okay.
Or their body might be clearing the hormone faster or binding it up more, like if they start oral estrogen therapy, that increases TBG again and raises their dose requirement.
Oh, okay.
And then, let's be honest, sometimes it's poor compliance. The patient might take a bunch of pills right before the blood test, so their T4 looks okay, maybe even high. But the TSH is still stubbornly elevated because they weren't taking it consistently before.
So how do you sort that out?
Sometimes a formal thyroxine absorption test can be useful to see if the gut is actually absorbing the medication properly when taken under observed conditions.
Gotcha. And just broadly, other drug therapies, things unrelated to thyroid.
Definitely. Loads of drugs can interfere, either directly with the HPT axis, the whole brain-thyroid feedback loop, or with how thyroid hormone is transported or metabolized.
Can you give some examples?
Sure. Amiodarone is a classic one. Lithium, newer drugs like tyrosine kinase inhibitors, even things like dopamine agonists or high-dose glucocorticoids can suppress TSH.
Books.
And one really important practical one, heparin.
Heparin. How does that interfere?
It causes the release of non-esterified fatty acids in the blood sample tube after it's drawn. These fatty acids can displace T4 and T3 from their binding proteins in the test tube.
So the test thinks there's more free hormone.
Exactly. It leads to artifactually high free T4 and free T3 results. The level in the patient isn't actually that high.
Wow. So what's the advice there?
Ideally, try not to measure frees in someone actively getting heparin infusions. If you must, collect the sample more than 10 hours after the last dose and get it to the lab quickly for analysis.
Good tip. Okay, so let's say we've thought about the clinical picture, NTI, pregnancy, levothyroxine issues, other drugs,
Right.
but the TFTs still don't add up. What's next? Could it be the lab test itself?
Absolutely. That brings us to assay interference. The tests aren't perfect.
How can they go wrong?
Well, in TSH assays, you can have interfering antibodies, things like human anti-animal antibodies, or HAA, sometimes called heterophile antibodies. They can basically cross-link the test regions, giving falsely high or sometimes falsely low TSH results.
Okay.
And free T4 and free T3 assays are notoriously tricky. Besides heparin-like effects, other antibodies or substances in the patient's blood can interfere with the measurement.
So if you suspect this,
You really need to talk to the lab. They might be able to run the sample on a different type of machine, use blocking agents, or dilute the sample. For tricky free hormone measurements, sometimes they have to send it out for equilibrium dialysis.
which is like the gold standard.
It's considered the reference method, yes.
Yeah.
It physically separates the free hormone. It gets around most interferences.
Okay, so we've ruled out common stuff, ruled out lab interference. What's left when the numbers are still weird? Like high T4, T3 with a non-suppressed TSH.
Then, and really only then, you start thinking seriously about the rare genetic and acquired disorders of the HPC axis.
Like what?
The classic differential here is distinguishing resistance to thyroid hormone, usually due to a TR-beta gene mutation, or RTH-beta, from a TSH-secreting pituitary tumor, a TS-HOMA.
They can look similar.
They can present very similarly elevated free T4, T3, but the TSH isn't suppressed. It might be normal or even slightly high. Symptoms can overlap too.
So how do you tell them apart?
Specific tests help. A TRH stimulation test, for instance. In RTH, you usually get a normal or exaggerated TSH response. In a TS-HOMA, the response is often blunted, attenuated.
Okay.
Pituitary MRI is obviously key to look for a tumor. Measuring alpha subunit levels can help, and sometimes a trial of a somatostatin receptor ligand, like octreotide, can help T-somas often respond, RTH doesn't.
And there are other rare things too.
Yes, other rare genetic conditions like mutations in the MCT8 transporter that causes Allan-Herndon-Dudley syndrome, or issues with deiodinases, or even TR-alpha resistance. They each have pretty unique TFT patterns, but they are definitely in the rare category.
Wow. Okay, so pulling it all together, the key message really seems to be, don't just react to a number. You need a systematic, structured approach.
Absolutely essential. Start with the patient, the clinical context. Then actively investigate those common confounders: illness, pregnancy, medications, compliance. Then work with your lab if you suspect interference. And only after all that, consider the rare stuff.
It really underscores how important that clinical judgment is alongside the lab results.
Understanding these potential pitfalls, these pearls and potential traps, it just leads to much more accurate diagnosis and ultimately better care for the patient.
Well, this has been incredibly insightful. We hope you found this discussion valuable for navigating those complex TFT results. It really makes you think, doesn't it? How much should we ever truly rely on a single lab number without the full patient story?
A crucial question.
Thank you for joining us for this deep dive. For more weekly topics and deeper dives into medical complexities, do check out our website. And don't forget to follow our Instagram page. We've got daily quizzes and takeaway summaries there too.